Hello, everyone, and welcome. I'm Kristen, owner and educator here at the Coding Corner. I'm truly glad you're joining me for this session on pacemakers and ICDs. In this session, we will walk through device types, indications, coverage rules, complications, and emerging technologies, all with clarity, compliance, and real-world practicality you expect from the Coding Corner. Let's get started. Here's our roadmap for today. We'll start with device basics, how pacemakers and ICDs work, and what makes them different. Then we'll walk through the device families you'll see in operative notes. Next, we'll cover CPT coding for implants, replacements, revisions, and removals. We'll look at coverage rules for NCD 20.8.3 and NCD 20.4. Followed by follow-up coding and complications. Finally, we'll look at emerging technologies like leadless pacemakers, SICDs, extravascular ICDs, and conduction system pacing. By the end, you'll have a complete coding framework. Let's start with the most important distinction. Pacemakers treat bradycardia. They pace when the heart's intrinsic rate is too slow. They include a generator and 1 to 3 transvenous leads. And they pace on demand only. They do not deliver shocks. ICDs treat life-threatening ventricular tachycardias or tachyarrhythmias. They can deliver anti-tachycardia pacing, cardioversion, or defibrillation. ICDs also include full pacing capability, meaning an ICD can pace, but a pacemaker cannot shock. The coding takeaway is critical. The therapy the device can deliver, not the diagnosis alone, drives the code family. Operative reports will reference several device families. A single chamber has 1 lead, either atrial or ventricular. A dual chamber system has 2 leads, typically used for AV block. A biventricular or CRTP system has RA, RV, and LV lead synchronization therapy. A CRT-D adds defibrillation capability, coded as an ICD with LV add-on lead. A subcutaneous ICD sits entirely outside the vascular space, no transvenous leads, and no bradycardia pacing. A leadless pacemaker is a self-contained capsule placed in the ventricle via a catheter and its own code family. Pacemakers codes start with identifying the chamber and the number of leads. Codes 33206 through 33208 cover single chamber atrial, single chamber ventricular, and dual chamber implants. Replacement codes 33227 through 33229 include removal of the old generator. Generator-only codes 33212, 213, and 33221 apply when leads are already in place. Upgrades such as 33214 include removal and insertion of the generator. Lead repositioning or insertion 33215 through 33217 is reported separately. Removal codes 33233 through 33235 apply to generator or lead removal, but do not report 33233 with 33227 through 33229. Remember, implant and replacement codes bundle the leads placed at the same session. ICD coding centers around the system type. 33249 covers insertion or replacement of a transvenous ICD system, single or dual chamber. Add-on code 33225 covers the LV lead insertion for CRT systems. Generator replacements 33262 through 33264 include removal of the existing generator. Subcutaneous ICDs use 33270 series, never 33249. Leadless pacemakers use 33274 through 33275 and include imaging guidance. Extravascular ICDs currently use Category 3 code 0571T, but always verify your payer coverage. Modifiers matter in device coding. 26 and TC split the professional and technical components. 59 XS and XU unbundled distinct procedural services, but only when documentation supports it. Modifier 78 and 79 apply during the global period for related or unrelated returns to the OR. KX may be required to attest NCD criteria. Modifier 22 requires a separate statement qualifying extra work. Implant codes include leads placed at the same session. Replacement codes include the removal of the old generator. Always check your NCCI edits, and a modifier never substitutes for documentation. CMS covers permanent pacemakers for non-reversible symptomatic bradycardia due to sick sinus dysfunction or second or third degree AV block. The bradycardia must be permanent. Reversible causes like drug effect or electrolytes must be excluded and documented. Symptoms such as syncope, dizziness, or fatigue must be tied to the rhythm. Documentation must include an ECG, Holter, or telemetry evidence, and modifier KX may be required to attest criteria, and implants carry a 90-day global period. ICD coverage includes sustained ventricular tachycardia, fibrillation, prior MI with reduced EF, below EF, and NYHA class criteria, and selected inherited arrhythmia syndromes. Coders must confirm EF value and date. NYHA class, arrhythmia history, and waiting periods after the MI or revascularization. Common denial drivers include missing EF, unmet waiting periods, lack of guideline-directed therapy, or indications stated only in the order. Category 3 devices require payer approval. Now that we've covered implants, let's look at what happens after the procedures. Follow-up, monitoring, complications, and emerging technology. In-person programming codes 93279 through 93284 require iterative adjustment and a physician report. Interrogation codes 93288 and 93289 apply when no programming changes are made. Remote interrogation 93294 through 93295 is reported once per 90-day period with documented physician review. Technical support 93296 is billed by the entity providing the service. Remember, remote codes cannot be billed more than once per 90-day period. Complications include pocket erosion, lead dislodgement, fracture, insulation failure, pneumothorax, perforation, venous thrombus, device malfunction, and inappropriate shocks. ICD-10 sequencing tip. T82 complication codes pair with an additional code identifying the specific infection or condition. Leadless pacemakers use 33274 through 33275. Newer dual chamber leadless systems require updated guidance. Subcutaneous ICDs use the 33270 series and have no transvenous leads. Extravascular ICDs use Category 3 0571, and payer policies do vary. Conduction system pacing uses existing lead codes but require precise documentation. Category 3 codes and device releases change annually, so always check your current CPT and payer policy. Here's your final checklist. Identify the device family. Count the leads in the chambers. Separate new implants from replacements. Confirm medical necessity. Track follow-up timing. Verify codes annually and never code from memory. Here's our first example. A 78-year-old patient presents with dizziness, near syncope. Telemetry shows second-degree Mobitz 2 AV block with ventricular pauses. Reversible causes, electrolytes, ischemia, and medication effect are ruled out. The cardiologist implants a dual chamber pacemaker with an RA and an RV transvenous lead. So what do we code on this one? This is a 33208. You can see here we have our second degree Mobitz AV block. Then we have their dual chamber permanent placemaker with the RA and RV. That brings us to that 33208 with the ICD I44.1 for the second degree AV block Mobitz type 2, followed by the R55 for the syncope. And this is a symptom supporting medical necessity, but remember it has to be tied to that block in order to bill. And as you can see, we have our coding rationale here for our NCD 20.8.3 that states that CMS covers permanent pacemakers for that non-reversible symptomatic bradycardia due to sick sinus syndrome or, and in this case, second or third degree AV block. Our next example, 65-year-old patient with ischemic cardiomyopathy, EF of 25%, a NYHA class 2 symptoms, and a prior MI 4 months ago presents for primary prevention of ICD placement. The cardiologist implants a dual chamber ICD with RA and RV leads. So again, we have our primary prevention of ICD. We have our dual chamber ICD with RA and RV leads. This leads us to 33249 with I25.5 for the ischemic cardiomyopathy, I50.22 for chronic systolic heart failure, and Z95.810 for presence of automatic implantable cardioverter-defibrillator. Now, the Z95.810 is not going to be applicable to the device itself for the implant. This is for when they are seen for follow-up visits. We also have our coding rationale for the NCD 20.4 showing the EF threshold. It shows the EF date, and it shows the 33249 is correct because it covers the insertion of the ICD system with transvenous leads. Thank you all so much for joining me today. Pacemakers and ICDs are some of the most complex but most rewarding in areas of cardiac arrhythmia management and coding. Hopefully you left today with knowing more than you came in with. And at the Coding Corner, it is my mission to give simple real-world education that is structured, supportive, and practical. Whether you're learning cardiac devices, E&M, surgical coding, or preparing for your next certification, you are part of a community that values accuracy, integrity, and growth. If you would like more resources, workbooks, or training opportunities, please feel free to reach out to me at the Coding Corner Medical Coding Education. We have email and our website on our Facebook page. We also are on TikTok and LinkedIn. And I want to thank you for joining me, and we will see you in the next one. Thank you all and have a great day.